My name is Jimmy, and on behalf of Outsourcing Center, we are proud to present today's webinar, Transform Quality Care by Strengthening IT Infrastructure. The presenters today would like to encourage everyone on the phone to submit questions throughout the presentation, and you can do so by typing your question into the field labeled questions on your console. Today, joining us, we have Steve Anderman. Steve was the Chief Operating Officer for Bronx Lebanon Hospital Center, from which he retired in January of 2014. He joined the hospital's executive staff in July of 1998. Prior to his joining the executive staff of Bronx Lebanon Hospital Center, he was also the Senior Vice President at another hospital in New York City. He has also had a public service career for over 20 years in the New York State Department of Health. For 18 of those years was involved in the healthcare financing program. We're very glad to have Steve join us today. We also have Uday Madasu. Uday joined Jewish Board of Family and Children's Services as their CIO in 2012 and has implemented various critical infrastructure projects. He has over 14 years of experience in healthcare, covering various areas like finance, operations, IT, corporate compliance, performance improvement, and quality assurance. These are two great speakers that we have joining us today to go over all of this information. And with that, I'd like to turn the presentation over to you, Steve.
Thank you, Jimmy. Thank you for the nice introduction for Uday and myself. Good afternoon, everybody. And I want to say first, and Jimmy, if you can get to the first slide, you as healthcare deliverers have a very daunting task ahead of you that started a transformation process, I would say, about 15 years ago and has dramatically accelerated with the adoption of Obamacare, or the Affordable Health Care Act, and with pressure on premium coming from the business community, the pressure on Medicaid affecting state budgets, and action that goes on every year with congressional messing around with Medicare. So today, I think one of the things we're going to try to do is at least touch upon some of this disruption that's going on, and our agenda's in front of you. We're going to talk a little bit about emerging healthcare trends, spend a little time on value-based purchasing, population health management, patient safety, and health information technology. Jimmy, the next slide, please. Unfortunately, being a little New York-centric, but I'm sure all of this applies to any place across the country. There was a recent study done, and of course, if you look at this chart, looking at risk factors, you see the usual suspects. You see issues related to frailty related with age, diabetes, cardiovascular disease, medication management, care coordination, cancer, healthcare literacy. I am sure across the country, and there's been some recent studies done, and if after this you could look at the United Healthcare Fund in New York's website, you'll see that in the Medicaid program, a large spend is related to patients with behavioral health care problems that have chronic diseases, and if I remember correctly, they probably spend, they're a cohort probably of 10 to 15% of the population. They spend a huge chunk of the Medicaid budget. And I'm sure this population trend sort of parallels itself in the Medicaid and the commercial world. Jimmy, next slide. So what we're going to do is talk a little bit about the new quality imperative, value-based purchasing, avoidable admissions, short stays, managed care, risk contracting. The big challenge, and that's baked into the Affordable Health Care Act, is this whole notion of value-based purchasing. Came on the scene about 5 to 8 years ago with Medicare laying out a couple of targets, and they linked the price movements from year to year to achieving certain results in the value-based purchasing and in avoidable admissions. And then the most recent controversy has been the controversy related to Medicare tamping down on short stays and observation rates by denying coverage. All of you are dealing, I'm sure, across your business lines with denials coming from managed care, risk contracting, and that's sort of being done in all the states. Population management is the new trend on the scene. As you're trying to manage risk, you need to basically look at what's going on with your population management. The ambulatory care push to have patient-centered medical homes for primary care. And we have the latest waiver process. California has received a Medicare waiver, Texas has received a waiver, and New York has received the latest waiver on these delivery system and reform incentive programs. And basically, and I can speak to New York a little bit because I'm familiar with it, and I'm sure people from Texas and California are familiar with that. What CMS is trying to do is they held out a carrot of a lot of money. In New York, I think it's $5 to $6 billion of a Medicaid advance to reform the healthcare system with the overall goal of reducing Medicaid costs, which are an increasingly large part of every state's budget. And with that, they've asked organizations across the state, the delivery system, both from the physician side, the hospital side, the long-term care side, to structure themselves into something called a PPS, I forget the exact acronym, but an organized healthcare system that will cover a certain amount of lives. And in New York, you've got groups ranging from 720,000 lives to about 50,000 lives, and there are 22 groups. And the hope is that these organized healthcare delivery systems will begin to bend the curve of healthcare economics as well as healthcare quality. And the chicken and an egg is that the feds in the state are willing to advance dollars, but you have to meet certain quality deliverables, whether that they're value-based or they're system-based related to reductions of overall cost. And lastly, underneath all of this, which is really some of what we're going to talk about today, is a health information technology that not only supports all of these activities, but allows the individuals like yourselves, the day-to-day decision makers, to make decisions related to all of these topics that are listed on this chart. Next slide, please. And just a little bit of slide here, just to sort of put the trends on the table. We've got this hospital-based purchasing. We've got a population health management, the latest bogey on the scene. We'll talk about patient safety in a little bit, which is coming to more and more of a fore. You're all familiar with the activities related to driving infection control, hand washing, Leapfrog group we'll talk about, and lastly, the cost-effective IT systems. And Uday, why don't you spend a couple of minutes to go over the other side of the chart?
Sure. Thank you, Steve. So in the presentation today, we are going to cover some broad technology areas like mobility, analytics, security and compliance, and interoperability to really understand how we can leverage technology to manage some of the healthcare challenges, and more importantly, the opportunities that are going to present themselves as the landscape of healthcare is going to change in the next couple of years. We'll get into a few details around what are some challenges and benefits of various technologies that are currently in play. We'll talk about some emerging or disruptive technologies, especially in mobility and analytics. And we'll also present a couple of technology use cases of real-life examples around these broad technology areas so that you can get a sense of how you can leverage the technology that's available today to deal with some of these challenges. Steve, back to you.
Next slide, please, Jimmy. Okay, a little overview on value-based purchasing. I hope I'm not boring anybody, but these are the real big topics of today. As I mentioned earlier, established in law by the Affordable Health Care Act, basically paying for performance, considering the outcome of quality, hope to improve the quality of care to individuals. The idea is to reward acute care hospitals with incentive payments for the quality of care provided, and the practices here are the best practices: quality care, patient experience, and outcome. Next slide, Jim, please. And as you see, the weightings are related to 4 different areas: clinical process of care, patient experience, which is HCAHPS for those that you know that an acronym. These are the patient satisfaction surveys that are done. Press Ganey, big player in that area. Outcomes and efficiency, and you see the weightings begin to shift, being driven by the Affordable Health Care Act in the outcome and efficiency area. Next slide, please. And here you can see for fiscal 2015 and fiscal 2016 where focuses are coming. And it's worthwhile just to give you you'll see in the middle of the page on the left, the AHRQ. That stands for the Agency for Healthcare Research and Quality. It's an agency that's funded by part of the federal government, funded by Congress and CMS. They do a lot of the healthcare service delivery research and outcome research that eventually gets adopted by CMS and put into regulation. So if we focus on the right-hand side, which is what you're facing now and upcoming next year, there are 8 clinical care measures, which we'll look at in a second. HCAHPS, which I already mentioned, which is the patient satisfaction surveys. And these, as you know, have been broadly debated across the country, whether the questions are fair, whether you're from a rural area, an urban area, a suburban area. The questions are really the same that are asked by patients across the board, regardless of their socioeconomic status. And I know if you're like myself, the only time you really ever respond to one of these surveys if you're annoyed about something, and then you generally give it a nasty review. So the outcome measures related to AMIs and heart failures and pneumonias, an ARC patient safety indicator, infection control issues related to central line infections, catheter infections, site infections, and an efficiency measure in terms of spending per beneficiary. Next slide, please, Jim. And here, drilling down a little bit, you can see the detail of the clinical process measures that they're focusing on in terms of looking at door to the cath lab time from the emergency room, discharge instructions, prophylactic antibiotics administered or not administered, post-operative urinary catheter rule. All of these measures, the the HCAHPS experience of care measures and the outcome measures in terms of heart failure, pneumonia, and other kinds of things. These are all derivative from the ARC research that's been done over the last 5 or 6 years, and now getting baked into from the Affordable Care Act, baked into the system. All, by the way, need to be driven from a robust IT structure in your institutions. I don't know how institutions can do this without a well-baked, well thought out information technology system. Next slide, please, Jim. And that sort of leads, if you've got the IT system in place, what's got to be built into this structure is a robust ability to be able to understand, manage, report on information. And that leads us to analytics. And I'd like to go back to Uday, let him speak a little bit about this. Uday?
Sure. So as everybody has been hearing the buzzwords like big data, healthcare is kind of catching on to the terminology. And so when we talk about analytics in the context of healthcare, we are talking about things like clinical outcomes, and we are talking about being able to visualize data around healthcare clinical data or financial operational data, and then on sort of the more advanced analytics, being able to really do predictive analytics so that we can prevent bad events from occurring and then having to deal with them. Some of the challenges in the analytics are really about managing the data, which sometimes could be unstructured data. Sometimes the data is unorganized and we have to figure out how to deal with duplicate sets of data. And then of course, technology is still very expensive. So sometimes the cost of implementing a good analytics solution in a healthcare agency could be very high. And then of course, you need to have the right level of skill set to be able to both implement and sustain a really good analytics model, and sometimes that is not easy. But if you can figure out how to deal with some of these challenges around data and capital and resources, the benefits are many, including being able to improve patient care, being able to improve clinical outcomes, and improving the operational efficiency, because you'll have the ability to look at data in real time, which will really help make some effective decisions to improve operations. Not to mention that all of this will ultimately reduce the cost and increase reimbursement. So analytics really is going to be the linchpin as healthcare providers across the country are trying to figure out how they're going to survive in the future. And leveraging technology is probably the best way for healthcare providers to deal with some of these challenges. Jimmy, if you could go to the next slide, please.
I'd like to add, Uday, Jimmy, you can go to the next slide. I'd like to add, Uday, one of the other challenges that you have with this, and I know Uday will talk a little bit about it, is when you're in these organizations that scale up to take risk for your clients, you've got to put together information from disparate health information systems. So not only your system that you operate on as a provider, but a whole range of systems that range from data from a doctor's office, from a hospital, from a long-term care facility, from a social service agency, because at the end of the day, what the state and federal governments are looking for you to do is care manage your population that at some point from a financial structure, you're going to have to go at risk for in order to be able to survive. Healthcare organizations, you know, basically we're in the sick care business, and you've been past, the past genres have been that you're paid on a fee-for-service basis, now switching to managed care. But unless you're at risk, as you reduce usage, which is what the pressure from business and government is asking you to do, you're basically cannibalizing yourself into bankruptcy. So what you've got to be able to do is get information organized across the whole continuum of those that are in your delivery system that are providing services for those who you're going to be going at risk for. I'm sorry, Uday. You can go back into the slides.
Sure. You know, just right along those lines, this slide basically shows a couple of technology use cases around analytics. Obviously, a lot of healthcare providers are now using electronic health records to be able to capture the services that they provide and the relevant documentation. So the first level of analytics is built right on top of the data that is being captured in the electronic health record systems. And that data is very real time. It drives clinical decision support, and it really helps providers make informed decisions around the quality of care and then ultimately improve client outcomes. A very simple example of analytics built on data in electronic health records could be a dashboard that talks about medication utilization to monitor dosage ranges, to monitor class of different medications to see if, you know, certain physicians are not using the right class of medications to have a positive outcome in the clients. Then there are, you know, then there's the world of analytics that extends beyond data that is in the electronic health record. There we are, you know, in that context, we are trying to figure out how to bring data from multiple systems. Sometimes those systems could be clinical, sometimes they're financial, and sometimes they're operational, to really, once again, understand what's going across an agency from various perspectives, and to be able to make some operational decisions, but then also to enable continuous performance improvement. And there are many tools that are available in the market today that really let you slice and dice data from multiple systems within the agency. And you know, it's not that difficult to leverage what's already in the market. Some of the things that we have done is we've built, you know, at the agencies that Steve and I work at, we've leveraged technology to build analytical platforms to not only look at cross sections of data, but really push the envelope and try to get into some predictive analytics and even do sentiment analysis around client satisfaction scores using both enterprise data, sometimes using unstructured data, and sometimes even pulling in data from social media. We are also using analytics to understand what's going on in the underlying support infrastructure. So we are working on building a platform for even analytics around data center automation, so that we can really make sure that the infrastructure that is quintessential for enabling healthcare providers to deliver quality care is working nonstop, and we are able to prevent problems before they occur. So we are really pushing the envelope with analytics to be able to make sure that things are working, and if they're not working, we know about them very, very quickly. Jimmy, if you can go to the next slide, please.
Yeah, thank you, Uday. Before I do that real quick, we do have our first question that's come in, and I do want to reiterate to the attendees, Uday and Steve feel like they're talking to peers. They want to keep this conversation as much as possible and not just kill everyone by PowerPoint. Please ask any questions during the presentation, and I'll do my best to interject them. The first question, which I think Steve was hitting on, maybe you guys can dive into it a little bit more, is how does the Health Information Exchange really fit into analytics today?
That's a great question. Sure. That's a great question. So as the health information exchanges are becoming popular across multiple states across the country, they're able to do something that we have not been able to do in the past, which is really allow us to break down silos of information. The data from health information exchanges is able to present a very, sort of rich clinical content that aggregates patient views from multiple sources. And the health information exchanges are augmented by really robust data warehouses that understand how to leverage both clinical and administrative content, whether it is billing information, what have you. However, in order to develop that foundation and in order to use the data that these health information exchanges collect, we have to make sure that there as many sources as possible are actually sending them quality data, because otherwise, we all know the saying, garbage in, garbage out. So it's very essential to make sure that the right sources are sending the right data across the continuum of care. But once the data is there, the value that comes from making it available where it is needed right at the point of care for providers, I think is great. And it really enables the providers to make great clinical decisions as they're providing care. Also, the health information exchanges using analytics, I think, have been able to improve the communication of information across multiple stakeholders, which further improves the coordination of care. The data there can be leveraged to really engage with patients and support new business models and manage risk, much better. Just to throw some statistics, in the U.S. healthcare system, we typically, the estimates around wasted opportunities are almost $55 million for opportunities that can be prevented, as high as $200 billion from delivery of unnecessary care, and again, another $130 billion from inefficient delivery of care. And the one thing that can make a difference is analytics, especially if you consider some of the very high costly conditions that Steve was talking about earlier, things like diabetes, chronic obstructive pulmonary disorder, congestive heart failure. A lot of these diseases, which are what we would call low-hanging fruit, can use analytics and, more importantly, predictive analytics to really do a good job of managing that population and those diseases, which will yield in substantial cost savings.
But I want to add, Uday, I mean, in all of this we're really at the beginning of the the health information exchange and analytic era. We're sort of compared to some of the other, let's say the EHR development, we're in the toddler stage, or maybe the young pediatric stage of the process. I know across various states in the country where exchanges are operating, we're at the beginning of the process, with the hope that technology will improve over time to help meet the challenges. Can we go to the next slide, Jim? Okay, I'm going to talk a little about, and Uday's talked a lot about population health management, which is really the one of our buzzwords for today. And to me, it really comes down to having data, having good quality, being able to measure quality measurement, performance analysis, and the ability to sort of look at all of this in real time in a meaningful way. You don't want to sort of be able to sort of get into searches and to be sitting there looking at waiting for days to get an answer. And it goes back to something that I said earlier. What's being asked of you as providers is, through this tool set, to be able to manage this group of individuals, provide quality, and provide it at a lower cost per beneficiary. And in order to do that, you're going to have, I would tend, and survive, and this is my hypothesis, you are going to have a risk contract with whoever, whether it's Blue Cross, whether it's Medicare, whether it's Medicaid, whether it's Aetna, whether it's an ERISA plan, a General Electric, because yes, as you are successful in terms of managing population health, you also need to be able to hold on to some of those savings as you bend the cost curve. Next slide, please. And here's just one little illustration. There have been lots of illustrations in the literature. I'm not going to spend really any time on it. You can go back to these slides. I'm sure Jim will make them available to you after of sort of what we're talking about. And again, the continuity, and I know, and I can speak to the district in New York, is not only from the doctor's office through primary care, through acute care, but as well as through long-term care. And it's going to be an interesting process to get all of these groups to play together and to share information together to bend the curve. Next slide, please. Uday, I think you're going to talk a little bit about and sort of getting people to sort of share data and talk to each other, interoperability a little bit. Sure.
So as Steve was talking about population health, I think one of the keys around being able to manage population health is really for providers to be able to share information about population across the board. And one of the ways to make that happen is having interoperable systems. So, you know, at a minimum, interoperability basically, you know, is the ability of systems to talk to each other and exchange information, but in a way so that that information can then be analyzed, can be and can be used. Because if the systems are exchanging information, but people on the sending side and the receiving side are not able to actively use that information in their ability to manage population health, then it's not really going to serve any purpose. So the concept of interoperability is relatively new in healthcare. It's a couple of years old, and a lot of the providers may have heard about the concept of health information exchanges. In the country, there are almost about 300 health information exchanges that are currently in play, with a lot of providers that participate in one or more exchanges that are actively sharing information about their clients. But interoperability also extends to device interoperability, so being able to connect devices and getting data from devices into the electronic health record system. And then we are talking about the ability of being able to engage with patients so that we can collect data from patients as they go about their normal lives, so that we can bring that data also into the electronic systems and exchange that data with other providers. Interoperability is easier said than done. There are quite a few challenges when you deal with interoperability. One of the big challenges around interoperability and being able to exchange every single piece of information that is captured electronically is interoperability standards. The standards are evolving, but we still have some work to do in terms of making the exchange of information very seamless. We are not there yet. Another big challenge around interoperability and being able to exchange information is obtaining patient consent. The regulatory requirements around healthcare providers that are governed by various regulations are very strict around whose information am I allowed to exchange, and I absolutely need consent in order to do that. And then the last challenge is just the diverse technology that is currently in play, and getting all of the technology vendors to be able to you know, collaborate collectively and then make sure that their systems are able to talk to each other. But the benefits, once again, if we can figure out a way to work around the challenges, there are just numerous benefits. I think the ability for accurate patient data increases, you know, tenfold. It reduces complexity around the ability to provide care. Ultimately, it reduces the cost. The most common example that we use when we talk about interoperability in the healthcare world is, if I'm a patient and I recently went to my primary care physician and got my blood work done, if something unfortunate happens and I end up going to an emergency room, most of the times the emergency doctor will reorder the same blood work. Wouldn't it be great if the emergency doctor can simply pull up my information from my primary care physician's record and be able to see what's going on with my blood work, so that he doesn't have to repeat a blood test that then, takes time, involves resources, costs money. Jimmy, if you can move on to the next slide, please. So, as I was talking about interoperability, here are a couple of use cases around interoperability. The technology that is, the infrastructure that is underlying is very critical to enable interoperability. Whether it is interoperability across multiple providers or whether it is interoperability within the same provider. Many times big healthcare providers use multiple systems because there just aren't enough systems that can do everything for a hospital. So many times you'll see hospitals use an electronic health record, but then they have ancillary applications like radiology, cardiology, lab, pharmacy, what have you. So one set of interoperable standards are to be able to allow different systems in the same agency exchange information, and you really need to understand how to leverage technology to do that. And then the other use case of interoperability is to enable providers to exchange information with other providers. Jimmy, if you want to move on to the next slide.
Yeah, thanks. Real quick, Uday, before I move on to the next slide, I do have a question. I've actually had a few come in. A couple I'm going to hold till the end. This one actually is in direct relation to what you're speaking to. One of the attendees just wanted to know, what are some of the technologies currently being used right now for communication to better manage population health?
Sure, that's another excellent question. There are quite a few communication technologies that are currently being used to manage population health. A few examples are as basic as automated follow-up patient calls. Then there are other examples of technologies around patient portal, so that patients can look at their own physical and behavioral health information, whether it is lab results, whether it is medications, whether it is educational information. Telemedicine is another great example of technologies that are used to, communication technologies for managing population health. Some of the other examples are around remote monitoring and medication adherence. However, it is important to note that for a lot of these communication technologies, I think some of the challenges for some parts of the country which are a little bit remote are around availability of bandwidth. Technology is not necessarily always reliable, so it's very important to make sure that whatever technology is being used is reliable, it is scalable. And then finally, as a lot of these communication technologies directly involve the clients, I think it's very important to make sure that they have access to the technology, because once again, cost is an issue. And then finally, the ease of use. Sometimes we deploy technology solutions that are just way too complicated, and therefore we are not able to get the benefits. I think it's important to make sure that people who are using these technologies really understand how to use them, and and they can take advantage of them. And then the last thing to keep in mind is, a lot of these technologies are evolving very, very rapidly. So I think you have to strike a fair balance so that you don't make a huge investment in a technology that might become very obsolete. So you've got to strike a good balance of what you're trying to accomplish and what you currently have available.
All right, we're going to talk a little and touch on a little bit of patient safety. I mentioned earlier in the presentation the Leapfrog group. It's worthwhile. Lots of hospitals participated, but if you're not and you're not familiar with it, it's worthwhile to go to their website. and see the kinds of things that they're asking for from institutions in terms of what you're doing. The idea of Leapfrog came from a push by a lot of large businesses across the country looking for value, patient safety in hospitals. And there's a very large questionnaire. Lots of hospitals are participating, some are not, that you fill out that go from your use in information technology in terms of physician order entry, medication reconciliation, what's going on in terms of automation and infection control in NICUs. And they also get into how boards have been educated related to patient safety and value-based healthcare delivery. It's an interesting survey. It's worth a look. Gives you the direction of what going to, but they've been a big driver in patient safety. The other things talking about is ensuring, again, quality of care, the technology implementations, trying to reduce errors there. The classic one to look at is physician order entry, computerized prescription barcoding, the whole medication delivery process, and to try to automate that. All trying to use technology to make the healthcare delivery process safer with better outcomes. Next slide, please. Jim. Okay.
Real quick, Steve, before we jump into this, got one more question around this that I think you can hit on maybe real quick. What are just some of the top patient safety concerns that you guys in your career have seen and continuing to see right now?
Well, I think that the big list, and I know ECRI has done some sort of listing in terms of what's gone on in 2015. I mean, one you've seen in the news in the last couple of weeks was just instrument sterilization, which has now popped up its head with some of the scopes, the endoscopes that are used across hospitals of the country. But to tick them down, alarm hazards, missing or incorrect data in our EHRs and other system, patient violence, particularly on the floors and in emergency rooms, IV drug administration, care coordination that's driven from a lack of med reconciliation, failure to perform some double checks, patient identification issue, substance abuse events, sterilization that I've talked about, and handoffs during patient transfer, and dosing errors related to weight, kilograms versus pound confusion. Those seem to be from ECRI, the latest. There's also, people can go look at the Joint Commission's website. There are their patient safety, their sentinel events that they're on their website. Uday, we're going to touch a little bit on security and compliance. I know you've talked a lot about it already.
Sure, it's an interesting transition. We're talking a lot about patient safety, and the next topic is data safety, because as much as we are responsible for making sure that we take care of the patients, we are also entrusted with their data, and it is our responsibility to make sure that we manage and protect and secure their data. So in this around this topic, there are again different areas. We are talking about data security. We are talking about how to encrypt the data so that we can manage any data breaches. So I'll kind of talk about a little bit, a couple of statistics, because the issue around security and being able to manage information is not just limited to healthcare. A lot of us are hearing some very bad horror stories involving big multinational companies, whether it is Target, Home Depot, Sony, but specifically in healthcare, some very recent statistics, about 68% of healthcare data loss occurs when devices are lost. These are devices that we as providers give to our staff, and when staff lose them, there is a risk of data being lost. Only 23% of data loss events are really due to hacking. And most of the times, the breaches are involved either with a laptop or a desktop or even a mobile device that staff use to be able to access patient information. And of those breaches, only a small number of breaches really account for some very large amount of data being lost. A couple of recent examples, the most recent breach that was huge was Anthem Inc., which is one of the country's largest health insurance company, and that breach involved almost 80 million customer and employee records. Another breach involved Blue Cross that also had almost like 11 million customers. One of the things that is interesting in the world of security is, in the past, we all used to hear about security around loss of credit card information, but recently, medical and healthcare records are becoming the Rolls Royces of the black market, and it is, it's estimated that the value of an individual record, which has patient information, is almost as high as $200 compared to the value of a credit card record, which have essentially become commodities, and they sell for something like $1 per record. So it looks like there's more and more value for protected health information, so security becomes very, very important. Now, since healthcare is a heavily regulated industry, there are a lot of standards. One of the big regulatory requirements for most all healthcare providers is HIPAA and HITECH standards, and they give us a very strong framework around things like administrative safeguards, physical safeguards, technical safeguards, and then even give us some guidance around risk analysis and risk assessment. So the concept of security and compliance, very, very important. The healthcare providers just cannot ignore those. There are several ways of dealing with security. There are, once again, a lot of technologies that are currently available to help deal with these security issues. Things like email encryption, device encryption, both device data in motion and data at rest. There is a requirement that we encrypt data. Then there are technologies that let you really monitor access, who's coming into your network, who's accessing what kind of data. So it's very important to make sure that you have a really good security framework. You do periodic risk assessments and make sure that you're doing your best to protect the data. Some of the things that I would urge people to look at is making sure that they have a very comprehensive IT visibility and control over all kinds of data transactions. HIPAA and HITECH are some regulatory requirements for most providers that deal with credit card information. There are PCI DSS standard, payment card industry data security standard guidelines. So I think it's very important to make sure that organizations have control over their data transactions, have control over the flow of information. They're really able to track and protect any kind of sensitive data, no matter where it goes. And then, one of the things to keep in mind is to make sure that we make security easy for users. A lot of the time, security is really around preventing good people from doing bad things. And sometimes we make security so complex that people set a very complicated password, but then they write it on a sticky and it's pasted right onto the monitor on their keyboard. What good is a very comprehensive password management policy if people are writing their passwords on sticky notes and putting it right on their PC? So I think it's important to make sure that you make security easy for staff, and then very important, make sure that you're training the staff on a periodic basis about why security is important, and make sure you've got written policies and procedures. And one of the other things I would also, strongly urge providers to consider is what happens if staff are just ignoring the security protocols. Are you going to be able to take them to task and make sure that security is something that they must take very seriously, because that is what is required in the current world. Jim, if you want to move on to the next slide, please, and the one after. So from security, the next topic we'll talk a little bit about is mobility. Once again, this is a hot topic. Healthcare is really beginning to take advantage of some of the mobility options that are out there. Obviously, there are a lot of choices around mobile solutions out there. Some challenges to keep in mind are when you talk about mobile devices, sometimes the devices are corporate devices, sometimes they're personal devices. So once again, security is an issue around how do you manage these devices, how do you manage data that's on these devices. You need to have device management capabilities even if the device doesn't belong to the corporation. But if you are able to manage the mobility aspect and take advantage of technology, then I think the benefits, once again, are multiple. You can really improve the efficiency and quality of patient care, but you need to make sure that you put in good mobile practices into play. Jimmy, if you want to go to the next slide, please. Some of the uses around mobility are, iPad or Android-based applications that allow providers to take advantage of EHR functionality. So, a great example for many healthcare organizations are ability of a doctor to be able to do e-prescribing when they're on the go, because many times patients may, have some emergency situations where they need a change in their medication. And if a doctor is not always in front of their computer to access the medical record, being able to use an app on their smartphone, tablet, what have you, to take care of the client emergency is great. And a lot of EHR vendors have figured out a way to leverage mobility. Then healthcare agencies are also leveraging mobility to bring a lot of technology right to the patient. There are a lot of apps that are available today to help patients manage, even things like depression. Patients.
Uday, I just want to respond. I know you've been talking a little bit about, mobility, but but from an operating standpoint, and I come from the operating world, one of the issues in all of this is what does the recipient, what's the provider can handle may be entirely different than what the user can do. And whether it's a elderly individual or a Medicaid patient who doesn't have access to the internet, or a patient who's in a rural part of the country who also may not have good access to things. I mean, all of this needs to be, I think, caveated in how this mobility framework sort of works out, because it depends on access to bandwidth, wirelessly or otherwise. And then the question is going to be is, how the individual accesses it and then pays for it. Potentially, is there going to be down the road a free wireless bandwidth that people will be able to have to, to talk to their doctors? That could be if that's what people want. I don't see that happening in maybe my lifetime, but maybe it will.
Right.
I'm sorry.
Well, no, you're right. A lot of what we are talking about really, on the patient side, accessibility and cost are two big issues. And, it is unfortunate that the availability of internet is not 100%, the same across all parts of the country. There are still areas where bandwidth is an issue. Hopefully, if Google's experiment with their drones and being able to provide bandwidth is successful, that might be the answer that we might all see in the near term. I think, Jimmy, that was basically what I wanted to talk about mobility, so we can move on to the next slide.
And this may be a good segue in, Uday. I got a question from an attendee that's a two-part question. It's incredible to have a former chief operating officer and a current CIO within the healthcare vertical right now talk about some of the challenges that you guys are overcoming and have overcome through strengthening your IT infrastructure in regards to quality care. This question is actually, I think, a good segue, and the question is stated something like this: where do you guys, where does Stephen, where do y'all see low-hanging fruit opportunities for hospitals right now within IT? And in furthering that is lowering costs with more immediate return type initiatives.
Well, I mean, I think the low-hanging fruit, I mean, Uday talked about it a little bit, I think is in the exchanges, because there's been funding from federal and state government to get the exchanges up, and I think that's where economies of scale are going to be. I mean, one could think, since Medicare really is a single payer, the federal government can come along and say, okay, we're going to have this great depository of Medicare data. We're going to put all the bells and whistles for biometric security around it, and if you're a Medicare recipient, all your data's got to go in there. So I think my hope is where the economies of change economy is going to be is there. I think the disruptive technology is on the mobility side, with what your mobile phones, which are really just now, which are really small little computers, and now what you can wear on your wrist. I mean, I would guess that the next step will be is at some point along the line, by reading something, they're going to be able to get an A1C hemoglobin, maybe even blood work. Who knows? I mean, I think that's where some of this disruptive stuff in, and now the last piece is really telehealth. There's now commercials on television, a funny one. I think it's for United that has two individuals who have an accident talking to their doc over their computer. So, I mean, I think all of this is, headed to where, we're going to be, in the future. And I'd just like to say, in sort of wrapping this up, and then we can turn it to turning to questions. Both Uday's and my organization did not really have resources to be able internally to sort of organizing all of this activity and supporting the infrastructure and helping us in the R&D area. And through our RFP process and stuff, I mean, we reached out to GAVS to help us implement our ideas, which has greatly helped us get to where we need to be as better, higher performing, healthcare system. So that's where I'd like to sort of leave it. I think we're open to if there are any other questions that have come in. I think Uday and I both would be happy to answer it. But again, you need, as I said at the end, you need a good team. Sometimes you need help from the outside in order to sort of put your hands around this very dynamically changing environment that the audience is living and breathing.
Appreciate that, Stephen. I want to be conscious of everyone's time. We know we've come to our time, and I have a couple more questions I'd like to get to. If the attendees can hang on, that's fantastic. If you can't, we completely understand. I am recording this, which you will get access to tomorrow. We'll be sending you out a link to the actual recording and to the presentation itself. Uday, though, I did want to give you a quick
an idea to respond to that question of what have you seen as far as any low-hanging fruit opportunities for hospitals' IT right now in regards to any lower cost with more immediate return types. If you wanted to respond to that.
Sure. The big one, I think, is analytics. There are many low-cost, very easy-to-use analytics products out there. I think that would be one area where you can really take advantage of existing technology that's not overly expensive to really be able to understand the data that you're collecting in all of your multiple systems. Now, having said that, sometimes the cost around analytics is not just the infrastructure and the technology. It really is the people cost. You need a group of people that really understand what is it that they're looking for, because you need to figure out data governance. You need to understand what are outcomes that are specific to the patient population and the type of provider agency, and then figure out how to get the data. So I would put my bet on analytics.
Okay, great. And then a second part to that question, which we may be able to use wrap up. If I don't get to all of your questions, because we have quite a few that have come in, someone from the presentation will reach out to you directly to help get these questions answered. But to that, a second part would be in regarding appropriate and early stage applications / data that may move to cloud infrastructure. What have you guys seen regarding that?
So if I understand the question, are you talking about what are some cloud-based infrastructure alternatives around analytics?
Around applications and analytics that you see moving to the cloud.
Sure. I mean,
infrastructure.
Sure. So both my current organization and the organization that Steve and I were part of earlier, we were definitely leveraging the cloud. A lot of the clinical applications, electronic health record applications, what have you, are offered as as a cloud-based solutions. So take advantage of those so that you don't have to worry about managing and maintaining infrastructure to run some of those mission-critical applications. So and those are plenty right now in the market, and you can definitely take advantage of those. On the infrastructure side, I think there are many examples of cloud-based applications. In the healthcare industry, I think people are a little bit skeptical about putting all of their data in the cloud unless they know it's a private cloud versus a public cloud. But there are definitely solutions out there that we can take advantage of as we speak.
Yeah, in my experience, Jim, the cloud applications have been in less the hospital-based information technology systems in terms of EHRs, but more in the physician offices and in the care management areas.
Yeah, that's a really good point. We actually had a question kind of come in on that basis of capturing that data. And to improve the data quality to perform those analytics, what have you guys been doing or implementing on the front end, from the clinicians to the nurses to the doctors, as far as tools to efficiently capture that type of data? What have you guys been implementing? What have you guys been doing?
Well, I've tried. I mean, at least my experience has been before my retirement is we were trying to capture information as part of individuals' workflow. And where it was different than normal workflow, we were trying to educate the staff. I guess it goes back to the value-based proposition, so we didn't get a lot of moaning of why do I have to, I've got enough keystrokes and other things to enter. I got enough sort of stuff to enter in my EMR. Why did I have to do it? So either we could bake it as part of the the workflow that was already there, and I think trying to embed stuff in individuals' workflow so it's just part of the daily routine, I think, is key. But if it's a little extra thing that you need to sort of meet some of these things that are now floating around in the environment, to make sure that the staff have the understanding of why we're asking individuals to do that, and then also make sure that you share at the end of the day the outcomes related to that. You know, here's the results of your work. Here's what we were able to do. Here's the success we've had. Those kind of things.
No, I think that's great. And I really want to appreciate you guys' time. I think at this point we need to wrap things up unless, Uday, you have any final statements you want to add to that question or any final last thoughts?
Not really, Jimmy. I'm good.
Absolutely. Well, I'll tell you what, it is such a pleasure to have, you know, like I said, a COO and a CIO, and for our attendees to kind of pick your brains a little bit about what you guys seeing going on in this device, with all the changes going on in healthcare right now. I want to thank you, Steve and Uday, for joining us today. I want to thank all of our attendees today for attending, and be on the lookout tomorrow for an email on today's presentation and a link to the recording. Again, if any of your questions weren't answered, we will also get back in touch with you right away. On behalf of GADS, we will be randomly drawing 3 people to have any free consulting, so that'll be great. So be on the lookout for that as always. Everyone have a great rest of the day and have a great weekend. Thanks again, everyone, for joining.
Thank you, Jimmy. Thank you, Steve.
Thank you, Jimmy. Thanks.
Thanks, everyone.